Good morning, everyone. I'm sorry, there was a slight problem with the microphone. I hope now all of you are able to clearly hear me. Welcome to the third webinar of Center for Evidence-Based Neurorehabilitation on Evidence-Based Recommendation for Constrained Use Movement Therapy, Part 2. Myself, R. Vasathan, neurophysiotherapist, who is a PhD scholar at Manipal University, will be presenting you with this part. For those of you who have not attended the part 1, we have provided the link to the part 1 and you could see that separately. So now we will start with the part 2 of it. What is constrained therapy? Constrained use movement therapy is a therapeutic package of behavioral intervention. It's a set of procedures which has some basic components and multiple components. And it does not include only exercises. It includes behavioral intervention, which is a psychological procedure. And it's applied to patients, stroke survivors in their acute, subacute, and chronic stages, especially people who do not use their arm for daily activities. CIMT works through a mechanism called use-dependent plasticity in the brain and is mainly targeted in preventing learned non-use of the affected site. What is a use-dependent plasticity? As we use the affected side more and more, the brain starts undergoing changes, and these changes are in fact learned, and the person is encouraged to prevent the non-use of the affected site. And learn non-use is a phenomenon where in the post-stroke period, as they recover from their physical disabilities, they start to try attempting activities. When they try attempting their activities, they learn that if they use the affected side, it is not very effective, and therefore they start learning how not to use the affected side. So it's a learned phenomena, and CIMT mainly targets to overcome that learning process. Basic components of constrained use movement therapy include practice of task-based exercises, shaping, transfer package, and constraint of normal arm. Practice of task-based exercises incorporates practice of functional activities which we perform, for example, eating, dressing, and other activities. And these are practiced both in the therapy session as well as in the home. And the second procedure is shaping, which is a behavioral psychology procedure called as operant conditioning, wherein we aim to reinforce positive behavior of using the arm of the affected site. Transfer package is a set of behavioral methods which are used to reinforce the learning and to convert the improvements which have been gained in clinic to ADL settings. And finally, the constraint of the normal arm is being done in order to prevent them from using the normal side. These techniques are not applied in isolation, but they are joined together and applied in a systematic manner for many hours per day for at least 4 to 6 weeks. And the CIMT protocol can be learned, and anyone who is interested in applying CIMT, I would like you to listen the part 1, which has been derived from the article Constrained Use Movement Therapy Characterizing the Intervention Protocol by Morris and Top, published in 2006. Whenever we learn about a new intervention, we are enthusiastic in applying the intervention, but the effectiveness, what has been claimed of that intervention, is not something what we will get. It depends on two factors. One is potency of the intervention, and number two, meticulousness of application. What's the potency of intervention is intervention which when applied to a patient, does it really produce a benefit sufficient enough for the patient to improve? And meticulousness is based on understanding and training undergone. Potency or efficacy is based on testing the intervention before driving it to clinical practice, and meticulousness is based on the individual therapist's understanding and the training process he undergoes before applying the therapy. In order to facilitate the understanding, we have uh, placed the first webinar, which discussed in detail about all the different procedures and how to apply the constraint-induced movement therapy. And in this, we will be discussing more about the potency of it and how it was tested and what's the quality of the testing procedure. Process of testing. Any intervention which needs to be applied in clinical practice has to undergo multiple phases of testing, from preclinical phase to phase 0 to phase 1, 2, 3, and 4. And normally, any medical intervention which is being applied goes through all these phases. So the normally, most of the physiotherapy interventions have been used without considering or taking them through these different phases. And so what we once thought was very effective turns out not to be so much effective. The potency of it is very minimal. But CIMT is one intervention where we have a lot of research to back up. And what we are going to see today is the evidence which has come out of those testing and the knowledge which we are going to gain out of these years of testing. And my whole would be predominantly on the recent evidences which have been published in 2015. So the questions we are going to address in this webinar will be the following. It includes the 4 subparts. Part 1 is, what is the quality of evidence? What is the research based on which this treatment is based on? Then we will be looking at what are the benefits of the treatment, and then we will look at applying the therapy in a clinical setting, and finally we'll come on to the most important question: can I give this to my patient? Steps of evaluating CIMT. CIMT has been tested, and once it is tested, we need to understand what was the quality of testing. If they have applied a CIMT without any control, then it's a very poor quality, right? And after understanding the quality of testing, we need to see how it has been collected, all the studies which have been done, how it has been collected, and whether they have been compiled appropriately mixed together. And after this, what we have done is we have analyzed the whole process and we have looked into quality of it. Right? Now, CIMT has been tested across the world through more than 42 high quality trials, which have been applied to more than 800 patients with 400 patients in each group. The quality of the testing procedure is good for CIMT, other than small problems here and there, but overall the quality is good. The findings of CIMT have been collected, and we can see that if you look down on the chart, there are more than 400 patients on whom the intervention has been tested. But there is one small problem when they identified when they collected it. You can see that there are many small trials. The column number 2, which you see over here, is the number of patients in the group. So each trial individually is having very less number of patients, but cumulatively we have a large number of patients for most of the important outcomes which we want. The compilation procedure, when they compiled, they identified that the positive studies are more as compared to the negative studies on CIMT, and this could add a bias to the quality of the evidence. But there are negative trials which are found. That's one of the issues for quality. Right? We analyze this entire procedure using a standard approach called as AMSTAR. And AMSTAR is a grading scale which is used to evaluate how high quality evidence is being taken. And in this case, a systematic review is being done, whether the procedure is fine and how it's applied. And recent evidence is based on a Cochrane review, which is a very high quality review, and it scored 11 on 11 on the AMSTAR. Further steps in deriving inference includes what is the direction of the result of all these studies. So in the previous slide, we saw about what are the different quality issues that might come when we are looking at evidence as it goes through different phases. And the next is, okay, given that this is a quality, right? What does the results tell? Do all the studies point in the same direction or they point in different direction? Say, for example, if 10 of the studies tell that it's effective and other 10 studies tell it's not effective, then it's really difficult for us to derive what to derive from that. But luckily for CIMT, most of the studies point in a single direction where it has been proven that it is effective. And the next issue in deriving inference is the directness of the inference. For example, we are aware, and if you have watched the previous webinar, you will be aware that CIMT produces, in fact, changes in the brain. But do you think this is a change which our patient would be more happy with, or our patient would be more happy with changes in their daily activities? As you might have correctly intuited, it is these ones which our patients would be very much interested in, all these activities of daily living. And most of the studies have taken this activities of daily living as an outcome, and that's a positiveness of it. And hence, on compiling all these evidences on the quality of the process of developing the evidence as well as looking into the quality of the benefits, we have come to a conclusion about the quality. And this is based on a very systematic procedure which is followed worldwide called as a grade approach. And the grade approach is used by most of the government agencies, including World Health Organization, in order to base its decision on. So at the current point of time, in 2015, the quality of evidence for CIMT should be considered as low. What it means is further research is very likely to have an important impact on our confidence in the estimate of effect and is likely to change the estimate. When you hear this, you might think that, okay, the quality is low. So does it tell that the CIMT doesn't work? It's not so. Let's understand what's the meaning of this low quality. Now, whenever we are going to take an intervention and try to apply it, we need to be sure that the intervention will work. And that can be looked upon in this probability line arrow, which you see over here. In this probability, if it says 100%, which means the probability if it is 100%, it means that constraint-induced movement therapy works definitely, and it will produce a benefit for all the people for whom we are applying. On the other hand, if the probability is 0%, then it means that CIMT does not work. It means that if you provide CIMT to patients, it will not improve. Right? However, the reality is research cannot completely tell that a treatment will never work, or it can tell that a treatment will definitely work, right? So the bandwidth we have after research for any intervention would be 20% to 80%. That is, there is more probability for this intervention not to work if it is 20%, and there is high probability that the intervention will work and if it is 80%. Now, the most important point in this whole line is 50%, which means if the probability of the intervention effectiveness is 50%, it means CIMT may or may not work. Now that's a problem. It's like tossing a coin. Say, for example, you're going to apply your CIMT to a patient, to a next patient, and you want to know whether it's going to work or not. If the quality of evidence is at 50%, then you're confused. You can instead toss a coin. If head comes, you can consider that the patient will improve and you can apply CIMT. If, on the contrary, if tail comes, then that treatment, the CIMT, may not work for the patient. However, at the present point of time, we are lucky enough that the evidence for CIMT is at this point approximately 65 to 70%. What it means is, on studying all these studies, right? Since there are more than 200 patients on whom CIMT has already been applied, and all these studies are telling us that CIMT works. If not all, most of the studies are telling that CIMT works, whichever are available in the public domain, right? And hence, the only thing is, what is the meaning of a very low quality evidence, as you had seen in the previous slide, is this estimate, the current estimate of 70%, 65 to 70%, in future research may move on slightly in this direction towards 50, or it might move on in this direction towards 80. So, to summarize, the quality of evidence tells that there are 70% we can be confident that CIMT will produce the benefits which we are going to see further. Benefits of treatment. Now in this part, this is the second part where we are going to look into what's the benefit of treatment. Now, primarily the benefits of treatments are looked upon after looking into the outcomes which have been taken in studies of CIMT when it was applied on outcomes. And the common outcomes they have taken are disability, arm motor function, perceived arm motor function, arm motor impairment, and dexterity. These are the outcomes which they have tested at the end of CIMT. Disability, they have tested using Barthel index or FEM, where, as you all know, it looks into the level of independence a patient can gain after a particular intervention on their activities of daily living. Arm motor function predominantly looks into the ability of the person to lift small objects and keep. And these are tested using multiple methods like Wolf motor function, action research, arm test, etc. Perceived arm motor function is what the patient perceives, and motor activity log has been used, which checks out how much the patient perceives that he is using the arm for his daily activities and what is the quality of such movements. And arm motor impairment is evaluated by looking into whether the patient is able to move the joints isolatedly. So Fugel-Meyer assessment is used for this, and we all know that Fugel-Meyer assesses whether the arm moves in synergy or they are able to isolate the movement across the joint. And finally, dexterity looks into coordination of moving the arm using tests like 9-hole peg test. And I hope any of the patient who is coming to us, who is visiting us, is going to actually be interested in one or other of these outcomes. And as physiotherapists, we also look into these outcomes. So let us see what is the effectiveness of applying CIMT alone. Now, first is independence in performing ADL. And say, for example, if when there are 100 patients who are given CIMT, at the current level of evidence, it tells that CIMT, on application of CIMT, 50% of the people will be dependent and 50% will become independent. Now, this is a scenario which I explained previously, like tossing a coin. What it means is, if your next patient comes and if he wants an outcome of independence in ADL, say for example, he wants to be independent in bathing, say for example, he wants to be independent in eating, right? Will CIMT help? At the present point of time, the effectiveness of it tells that we may not be able to tell whether our patient will become dependent or he will become independent on application of CIMT. The second outcome is arm motor function, and I'm going to use a sample test, the action research arm test, in order to help us understand what's the amount of improvement that comes with this. Action research arm test basically tests about the ability of a person to grip and grasp different sizes of objects and different shapes of objects. He's asked to lift and place it. And there are totally 19 components in action research arm test. And each of the components is scored on a scale from 0 to 3. And 0 means he's not able to move at all. 1 means he's able to move or perform the task partially. Say, for example, lifting the ball and placing it on the top panel, right? He may be able to do it partially, which means he might be able to lift it, but he may not be able to complete it. Scoring 2 means the patient is able to complete the task, but it takes abnormally long, very long time to perform that. And 3 is normal. So if you see the cumulative score of action research arm test, it can vary somewhere from 0, which is 19 into 0 is 0, or the patient can be as well as 19 into 3, which is 57. So the scoring on action research arm test moves from 0 to 57. And I hope you understand what's the score, what does the score mean, right? Now, the outcome on action research arm test has been something like this. If the patient comes initially, he will not be coming with 0 or no movement. Basically, because we have seen the criteria for applying CIMT is at least the patient should be having minimal ability to extend and open the fingers like 10 degrees or 20 degrees. So the baseline arm function with which a patient might come to us who will be eligible for CIMT and for whom it might work out is having a score of 20. What it means is on all these items, grasp, pinch, grip, and gross movements, on all these items, the patient might be having a score of 1. Or it might happen that he might be better in certain components like gross movement and grasp, but poorer in other components. Okay, right? The minimal improvement which is expected out of a CIMT is additional 10 scores, which means that of this whole list of items, the patient may move, if he has come at 1, he might move to 2 in at least half of it. You can see that there are 20 items, approximately 20 items. So in 10 items, if he improves by a score of 1, then obviously the score will go to 30. So if a patient comes with ability to do it partially, he might develop the ability to do it completely, but he might take abnormally long time to do it. And the maximum improvement which might come is 40, which means in almost all the components, the patient might have improved by a score of 1, or in some of the components which are far easier to improve, he might improve by a score of 2. So ultimately, the cumulative effect of CIMT on arm function is goes somewhere between from the baseline to 10 score improvement or a maximum of 20 score improvement. I hope you understand what's the meaning of this improvement in arm function. The third is improvement in quality of movement and amount of arm use. This is evaluated using motor activity log. Motor activity log is a list of activities which the patient is expected to perform using the affected side, like turning on a light with a light switch, opening a drawer, removing an item or clothing from a drawer, picking up from a phone, etc. Now, the patient is asked to tell how much he perceives that he uses his affected arm for these activities, on these activities, right? And what's the quality of it, right? The quality is scored on a scale from 0 to 5, where in 0, he does not use arm for any activity, the weaker arm, right? And he slowly starts using and it is beneficial. So in 1, the patient tried using it, but it was not helpful. 2 is the patient moved it, but it moved more slowly or with difficulty. And 3 is the weaker arm was used. It was the movements were slow, but still he made with only little effort on it. So like this, the quality of movement can improve. And all these are perceived quality, which means what the patient might perceive after application of CIMT. So say for example, if 10 patients come to us with a score of 1 uh, on the perceived, on the motor activity log perceived improvement in quality, then what is the effect of CIMT is for 3 patients, they might not improve at all. Another 3 patients can improve from very poor to a poor quality of movement, and other 3 patients might improve from, if they come at very poor, they might improve to fair quality of movement. This is the amount of improvement which different sets of patients might get after CIMT. The next issue is about whether they are using the arm more and more, the affected arm, right? And it is scored again on a scale of 5, where 0 is not used at all, and it goes very rarely half pre-stroke to same as that of pre-stroke. So in this outcome, if 10 patients come, right, at the end of CIMT, you might see that 3 people might improve, right, to using it rarely, right? 3 more people would improve to half that of pre-stroke, and other 3 will improve as good as 75% that of pre-stroke. These are the perceived improvements. Understand there is a difference between perceived improvement and actual improvement. Okay, right? So whatever I communicated in motor activity law is about the perceived improvement. The next outcome is dexterity. If the patient is asked to perform a 16-hole peg test, and if he initially comes with the ability to complete it in 1.5 minutes, the patient may improve as much as completing in 1 minute. And arm impairment as measured using Fugel-Meyer scale. If you look at a Fugel-Meyer scale, right, there are many components, and in this key form scoring form, it is a special form which shows the different components on a Fugel-Meyer. The ones which are there on the bottom are the ones which patients normally get an improvement in the early stages, and as they progress slowly and slowly, patients will start improving through these middle stages, and these are the ones which many patients do not get to improve. Now, what they have identified after CIMT is if the patient are having very minimal ability and they are coming to us, right, then after CIMT, they have found to improve by 8 points on the Fugel-Meyer scale, which means that if they initially have the ability to perform all these lower level tasks like cylindrical clasp, sacral elevation, finger mass flexion, then after application of CIMT, you will see that patients improve and they are able to do these following things like scapular retraction, pronation, supination of elbow to 90 degree, shoulder flexion to 90 degree. These are the improvements. And if they initially come with a higher baseline, you might see that they will be improving by another 8 points. That's how it is an improvement in the Fugel-Meyer form. So in summary, what we have seen is not only whether CIMT is effective or not effective, we have seen what is the magnitude of effect of CIMT on different prevention. And these have been based on the results of large number of high quality studies which have applied and seen a change. Now, the most important question is we all will have in our mind is what is the differential outcome, or if I apply CIMT, will my patient improve? But for that, what we need is what is the current level of improvement you are having currently. But many of us in India are not accustomed to using these scales. But however, since we have discussed, you will have a better understanding of what these scales mean, and you might also have perceived it. So let's look into what's the differential outcome of it, right? If a patient with the ability to extend his fingers by 20 degree comes for treatment, if his goals are one of the following, like improvement in ADL, arm function, perceived quality of movement, or dexterity or impairment, after you apply CIMT for a period of 6 weeks, the expected benefits are the following, which I have shown here. These are the expected benefits out of CIMT. Now, if you score, which I'm going to come further on, if you score a low score, if your current benefit by application of CIMT after 6 months is slightly less, then the green ones, what I give over here is a recommendation that you can apply CIMT. The yellow one, what I have given over here is if the improvement you are getting is so much, then you can try applying CIMT. And the red ones are if you already are getting this much amount of improvement, then you need not think of applying CIMT. Now, what are those improvements? We will see, right? On ADL, we have seen that CIMT is not able to help us out in coming to a conclusion whether it will help or it will not help. So there is no point in discussing about it. On arm motor function, if your patient after end of 6 weeks of treatment, he is actually dropping the objects and he can do only gross movements and he scores 5 on your action research arm test, then probably you can apply CIMT and it will definitely be better. If, on the other hand, if your patient is able to lift big objects or move slowly, right, then you might think of applying CIMT and it might be beneficial for your patient in improving further. But if your treatment currently what you're giving at the end of 6 weeks is already producing a large improvement as a magnitude of 25 on about on 57 in action research arm test, then this CIMT intervention may not be effective. On a similar note, if the patient's perception of the quality of improvement movement is very poor at the end of your treatment, then you can apply. If it is poor to fair, it is improving from poor to fair, you can still think of applying CIMT. But if the improvement is poor to almost normal at a 75 percentage, then if you try CIMT, it might not be more beneficial than what you are currently giving. Perceived arm use, on a similar note, the patients who are not at all getting an improvement or not at all using them, you can apply CIMT. And people who have started using it more after your intervention, you can really not think of CIMT. And in dexterity and in the impairment, these are the changes. If your level of improvement is beyond at this level, you don't apply it. If it is at these levels, you can still think of applying CIMT. So what I have made is I've bridged the gap between what is the improvement that have been identified through research studies on multiple patients, a large number of patients, and how you can evaluate yourself what is the current improvement, and on based on this, could you try using CIMT? That's one. But the question doesn't stop here on selection of CIMT. We need to look into the cost part of it. CIMT is a very wonderful intervention. It produces positive results and all these things. But yet, what is the cost of applying CIMT? The cost we will be looking in the following forms. One is harms of applying CIMT, the behavioral cost, operational cost, and financial cost. What is this? If CIMT has been seen to produce benefit, but it also produces some harm, then we may need to really doubly think before application of it. The next is behavioral cost. What we mean by a behavioral cost is how much hard it is for the patient to take the treatment. That is what we are thinking. All right. The next is the operational cost of application, and the last is financial cost of application of CIMT. Harms, CIMT does not produce any harms. That's a good part about CIMT. Cost of therapy, if you are currently giving any therapy, if you are planning to apply CIMT, it is going to additionally cost 45,000 rupees for the patient. This is incorporating 2 additional hours of a therapist's time. If he charges 700 for 6 weeks, it's going to be 16,800 rupees. And the caregiver who has to be there along with the patient in order to come and take the therapy for those long hours, and including the cost of waiting charges of the vehicle in India, right? A modest 45,000 rupees if you're going to apply CIMT. If you're based on a hospital, and if you're going to call the patient going to apply CIMT, then currently there are some centers in India which do apply CIMT, like DC International Rehab in Bangalore, and there are many multi-specialty hospitals which have started giving package treatments, and the cost varies somewhere between 15,000 to 1 lakh per month. And hence, the differential financial cost of applying CIMT may vary somewhere from 50,000 to 1.5 lakhs. The next is behavioral cost. This is a very important cost because a treatment we might be interested in applying, it might look very beneficial, but if the patient doesn't like it, then it's going to be very hard, right? So it has been identified that CIMT works well in patients who are motivated to undertake the practice of long duration. They need to consistently practice for a minimum of 1.5 months, and they need to actively practice it. And they need to overcome their physical difficulties. Some of the physical difficulties they might be having, like pain or fatigue, which may limit their ability to participate. And therefore, the patient should change from treatment taker to treatment performer, which means that he is going to do a lot of work in the department as opposed to the current practice in many of the places where we as therapists give a treatment, right, to the patient taking an active role in his treatment, and he is motivated and he is performing all the activities. So the intervention CIMT might have a behavioral cost and it might not work out well with all the type of patients. Finally, the operational cost of it, right? It's going to operational cost. We'll be looking into time, training, and materials required. For a patient, they might need to spend 3 to 6 hours per day, and a therapist it might need to spend 2 hours additional hours of therapy time. So he might need to be willing to sacrifice the treatment of 4 other patients for Avna, or if he's seeing a private patient, he needs to be at least willing to sacrifice 2 patients. That's the operational cost of it. Therapists have to undergo training, at least a 1 day workshop plus trial on 5 patients is advisable, and the materials he has to prepare and give it. So the intervention of CIMT involves this operational cost also. So in summary, when you are planning to apply CIMT, it's going to involve all these costs together. So you need to consider all these costs before thinking of applying CIMT. So now it's decision time. I hope all of you are waiting for a very long time to come to what is the ultimate verdict. Should I apply or I should not apply? And so on evaluating the quality of evidence, the benefits that are coming out of it and the costs of it, the recommendation we would like to give is, there are going to be 2 recommendations. Recommendation 1 is, as therapists in India, we may consider applying CIMT for a modest improvement in arm motor function and for a small improvement in dexterity, perceived arm use, or individual joint movements. 2 patients who are motivated, who are willing to spend an additional 50,000 per month with ability to extend finger and wrist at least 10 degrees and spend an additional 3 hours of independent practice at home for in the next 1.5 months. And the therapists who are going to apply it should undergo training in behavioral intervention with a senior therapist or in discussion with a psychologist. That's highly recommended. So if in final comparison, if you have to improve your practice and in your current practice you are not providing CIMT with all the contents as we have discussed previously, right? And if 3 of your patients are improving out of 10 patients who are coming, then if you apply CIMT, you can be 70% confident that 6 of your patients will start improving after CIMT for the benefit what we have discussed previously, right? And the second recommendation I would like to give is, therapists should not apply CIMT for gaining independence in ADL and to patients who are not having extension of more than 10 degrees, not motivated to spend time or energy for a period of 1.5 months, or who expect passive modes of treatment as they are more used to it and who are unable to spend a minimum of 50,000 rupees, and it should definitely not be applied without sufficient training. Thank you, and I hope this webinar would have opened your eyes to what is the evidence behind CIMT and what are the intricacies we need to think of before applying CIMT. So if you have any questions or doubts in this, you can go further on and we can discuss that out about the evidence. And if you have any further queries, you can email to me, myself, vasathan@gmail.com or hariom@hotmail.com. Thank you all for your patient listening, and especially those people who have come online and who have listened to it. Thank you.